right, thank you very much, Scott, and thank you to Dr. Perry and DSF for organizing this meeting and inviting me to be here. It's very exciting to be here in person. So I'm going to be talking about rescue medications and seizure action plans. So here are my disclosures, and really no relevant disclosures for the content. So what am I going to talk about today? First of all, we'll talk about what types of seizures need rescue therapy and why. We will, I think most of us have heard about status epilepticus, so we'll talk about exactly what do we mean by that, and what's the difference between convulsive and non-convulsive status epilepticus. What are the risks of both of those seizure types in persons with Dravet syndrome? We'll talk about what is a seizure action plan. I think most of you are all too aware of what these are because you use them a lot. But we'll address sort of the pre-hospital seizure action as well as in-hospital action management. And where do you get one? What rescue medicines are available? And we'll talk about the pros and cons of each of those so you can decide which one is best for your loved one with Dravet. And then what happens if the rescue medicines don't work? So first of all, what is status epilepticus? So traditionally, when I trained in neurology, which was unfortunately many years ago now, we defined that as a seizure that was ongoing for longer than 30 minutes. And that was either a single event lasting longer than 30 minutes, or sometimes people can have clusters of seizures where they go back to back to back into seizures and they don't recover. And if that period goes longer than 30 minutes, that was also considered status epilepticus. But I think we've become smarter, and we now use a definition of 5 minutes. So if you have a convulsive seizure or a cluster of seizures that lasts longer than 5 minutes, that is now considered status epilepticus. The term refractory status epilepticus, that sounds worse, and it is. And the term or the definition for that is if you have status epilepticus that continues despite getting a good dose of benzodiazepine, midazolam, diazepam or lorazepam, and then at least one second-line anti-seizure medication, something like valproate or Keppra. And then we use the term super-refractory status epilepticus if someone is having status epilepticus that goes longer than 24 hours, that actually requires induction of coma, medically induced coma, or if someone has a medically induced coma and is coming out and goes right back into status epilepticus. And then the term convulsive versus non-convulsive. All what convulsive means is that there is either focal, so on one side of the body, or generalized, both sides of the body, rhythmic jerking activity. Okay, so if somebody has rhythmic jerking activity, that's considered convulsive. And non-convulsive is typically an altered awareness. So we don't see that rhythmic jerking activity, but they're clearly not their normal self, they're clearly out of it. And oftentimes they can have little myoclonic jerks, but not the focal rhythmic jerking activity. So this is work from the International League Against Epilepsy, and it was published now a number of years ago, but this is where they changed the definition of status epilepticus. And so you can see here, looking at the types of status epilepticus, convulsive is the one that we most worry about in persons with Dravet syndrome. And then there's the non-convulsive. And they define 2 time points. So time point 1 is 5 minutes for convulsive and about 10 minutes for non-convulsive. And that is the time point where emergency treatment should be started. And that is because if a seizure is lasting that long, it is unlikely to stop on its own, so we want to treat that as quickly as we can. And in reality, many of you with children with Dravet syndrome treat much earlier than 5 minutes, right? But that would be sort of the last or the latest we would want to start treatment. And then the second time point, T2, is the time at which long-term consequences of that status epilepticus can be seen. And so we really want to be sure that that seizure has stopped well before this time because we don't want that status epilepticus to result in any brain injury. So really this is the T1 is really when we really want to have that treatment started at the latest. So let's talk about how seizures could potentially lead to brain injury. So they could do so directly. So if you have a very long seizure, that can actually injure brain cells, and that's because there's a lot of excitation happening in the brain, and that causes inflammation of those brain cells, and that can lead to permanent brain damage. But seizures can also indirectly cause injury to the brain, and that's because they can impair oxygen and blood flow to the brain. Oftentimes with a long seizure, people can have suppression of breathing, so they still often breathe, but they don't breathe as deeply, and there can be less oxygen coming in. Sometimes seizures can result in vomiting, and then the person during a seizure can actually breathe that down into the lungs. That's called aspiration, and that can also impair the oxygen getting into the bloodstream through the lungs. Seizures can also lead to blood pressure instability, sometimes very high blood pressure, more commonly very low blood pressure, and you need blood pressure to get blood into your brain to give it oxygen. And then as well, if you have long seizures and brain swelling, that brain swelling can impair further blood flow to the brain. So looking at the risk of prolonged seizures, there have been studies done in children in the intensive care unit with status epilepticus, and those studies have shown actually that the more EEG seizure activity that we see, the poorer outcome that child has. Now, this is a little bit different than most cases with Dravet syndrome because most of these children have some type of an acute brain injury. They've had a stroke or a head injury or a bleed or something like that. Whereas children with Dravet syndrome don't, right? They just have a genetic predisposition towards recurrent seizures. And in those children who have had acute brain injury, while we really want to treat those seizures as quickly as we can, sometimes that is not enough to necessarily improve long-term outcome. We think that children with Dravet syndrome are probably at somewhat lower risk because they don't have that acute injury, but that does not equate to no risk. And so we still want to be as aggressive about those time points and treatments. The one thing I wanted to address briefly is the issue of a concept called acute encephalopathy. This is a very rare or relatively rare disorder that we see in Dravet syndrome, but it's one that we really want to be aware of, and this is why we are so careful about trying to prevent prolonged seizures and to treat status epilepticus quickly. There have been a number of reports, case series reports of children who have this, and we don't exactly know the number, but the suggestion is maybe it affects between 3 and 7% of all persons with Dravet syndrome, and is most common in young children. And in these children, there is a febrile status epilepticus, so they have a fever and then a prolonged seizure. And while most children with Dravet syndrome who have that will then wake up and be fine, these children are not. They remain comatose, they don't wake up. Or if they wake up very, very different than they were prior to the seizure. And so this has a very high risk of what we call morbidity, so new neurological deficits, and a fairly high risk of mortality. On the MRI in these children, when this happens, we see acute brain swelling, and then over time, the brain becomes much smaller than it was before. And we don't know exactly why this happens. This seems to be related to the underlying sodium channel abnormality, but what's still a puzzle is why does it happen with that one seizure when many of these children have had 10 or 20 or 30 seizures beforehand, and it hasn't happened. So we still don't really understand this very well. And here's just some examples. So this was Myers, a group from Australia, and you can see here this is an MRI before, and here we see a lot of brain swelling after that seizure. This is a study out of Japan, and the white areas indicate swelling or abnormal swelling of the brain, and you can see fairly diffuse brain swelling. And then this last study was a study out of China, and we see very marked swelling on one side of the brain. So looking at this predominantly affects young children. So you can see here in the 3 case series that were reported, here is the average age of the children, and most of the children are, less than 5 years of age. The duration of status epilepticus is very, very prolonged. So some of them even up to 12 hours. And this is why we want to be so careful to stop that seizure and start treating seizures very, very early. Almost all of these children had associated fever. And looking at the outcome, you can see fairly high rates of mortality. And of those who did survive, they all survived with significant disability. So which patients with Dravet syndrome are at highest risk of status epilepticus? Bottom line, I think this is a risk for everybody with Dravet syndrome, so everyone needs a plan. But as we had already heard, status epilepticus is most common in young children less than 5. We do see a decrease in the frequency over later childhood and adolescence, and it is rare, but certainly not non-existent in adulthood. So let's talk a little bit about seizure action plans. So what is a seizure action plan? What is the information that we need to list on the plan? And so the goal really of a seizure action plan with rescue medication, here's your little seizure, and you want to avoid this, right? This is really what you want to avoid. And the reason we want to have a seizure action plan is because we know that if you don't, the likelihood of starting medication in a seizure is going to be very delayed. This was actually a study that was done from a number of children in pediatric hospitals in the United States. And it was found, so the average age of the child was 3.6 years, 81 children studied. It took 28 minutes on average before they got their first medicine. It took 40 minutes on average before the second medicine went in, and nearly an hour till they got their third medication. Now, most of these children had seizures that began outside of hospital. And that's why it's so important for families to have the tools to start that treatment much earlier, because you do not want to wait half an hour for your child to have a first treatment. So can status epilepticus be prevented? Not always, but I think if you have a home rescue medication and a plan as to what should be done if that home rescue medication doesn't work, at least we have the ability to have people treat much earlier. So we'll go through quickly a seizure action plan and what that should include. There's a number of different plans out there. Most of them are quite similar, and most of the medical record systems will actually have specific seizure action plans. This is just taken from the Epilepsy Foundation. So who needs one? Anyone who has a previous seizure emergency or who is at risk of an underlying seizure emergency due to the cause or the syndrome. That is everyone with Dravet syndrome. And this is particularly important for people who live a distance from emergency medical services or who travel in areas where emergency medical services are limited. So here is just some screenshots from what a typical seizure action plan should look at. So first of all, you need your demographic information, your child's name, the emergency contact, and then you need a little bit of information on what those seizures look like. So if it's not you there, somebody else is watching your child, they'll be able to recognize that that child is having a seizure and what type of seizure it is. There's then a response, how to respond to a seizure, and so it gives people information, what to do, when to call 911, who is the emergency contact, what hospital do they typically get taken to, and then importantly, when should rescue medicine be given? And for people who have Dravet syndrome, they can have different types of seizures, so you may want to give rescue medication for one type of seizure, for example, generally a convulsive seizure. But if you have some myoclonic seizures or an absent seizure, that may not require rescue medication. So you want to be very clear about what seizures should get rescue and what type of rescue and what dose. And particularly for Dravet, we want to include instructions on repeating the dose, if you're able to do that. And then care after a seizure, what type of help is needed, and when is that person able to resume normal activity, any other special instructions. And then if they go to the hospital, you want some information about what daily medicines they're currently on. And then other information, seizure triggers, any other significant medical history, any allergies they have, particularly to any rescue medications they might get, whether they have any neurostimulation devices or on ketogenic diet. That's important if they get taken to hospital, somebody starts an IV, you don't want to give them something with a lot of sugar in if they're on a ketogenic diet, and then their healthcare contacts. So those are seizure action plans, and those are generally available from your child's neurologist or your adult neurologist for the those in the audience with adult children. So I wanted to talk briefly about the different FDA-approved home rescue medications and the non-FDA home rescue medications, so the pros and cons of each of those. So the one that we've had for a long time is Diazepam Rectal Gel, and probably most of you in the audience have too much experience with this. So this is FDA approved for children 2 years and older. I think in reality, many of us use this in much younger children because we don't really have other good options. It is pre-dosed, and so that dose is set by the pharmacy anywhere from 2.5 up to 20 milligrams. It's given rectally, and so that's a bit of an issue if you were giving it for an older person outside of the home. This is socially, I think, a little bit more challenging if you're giving it in a school situation or a shopping mall or things like that. So it's certainly most appropriate in my mind for young patients, and it can be used or can be also appropriate if it's given in the privacy of one's own home. We have been fortunate actually in the last couple of years that the FDA has approved a couple of new nasal medications which are much easier to give, and these are designed to be given by lay individuals. So first is nasal diazepam. This is now FDA approved for 6 years and older, and it comes in this single-use device. This goes up one nostril, and basically you just push the plunger and it gives the dose. So there's nothing about somebody having to draw up a dose, it's already pre-dosed. And easily can be given by a lay person, and the school nurses really love these devices because it is a lot easier to give a child this medication than a rectal medication, and certainly much more appropriate for a public setting. And then there's also nasal midazolam. The device looks almost or essentially identical, just a different medication in it. It is approved for persons 12 years and older, again, pre-dosed in a single device, and again, easily given by a lay person. I guess the downfall of these is that these are single-dose devices. They're a little bit more costly. For some of them, there are copay cards online, so you can actually, if you're somebody purchasing this, you can actually save a fair bit of money using that. And then we still use a fair number of non-FDA approved home rescue options. So first of all, the oral solution, the Intensol, there's diazepam and lorazepam Intensol. These are little vials of liquid that you draw up. The lid has a little eyedropper, as you can see. And so you have to draw up the appropriate dose, and they generally go into the buccal cavity, so between the teeth and the cheek, and are pretty easy to give. The lorazepam version is not stable if left out, so that needs to be refrigerated, which is a little bit more challenging if you're carrying it around. The diazepam is actually stable at room temperature. Then a lot of people also use clonazepam. These are oral disintegrating tablets. You just put them into the cheek cavity and they can dissolve pretty quickly. These are pre-dosed. There's a bunch of different sizes, anywhere from 0.125 milligrams up to 2 milligrams. And it rapidly disintegrates and is absorbed. And then some people are still using, just for cost reasons and for younger children, the nasal midazolam that is not the nasolam option. So this is an IV solution. Typically you draw up a specific volume. You have this little nasal atomizer that you stick at the end of the syringe, and that just aerosolizes it. So you put that up one nostril and then you give the medication. This is a little bit, I think, more challenging. So some pharmacies actually sell this already drawn up in syringes, but it's a little bit more of a hassle to carry around. And then sometimes you can just have it in a glass vial, but again, it's a bit of, your child's having a seizure, you're breaking open a glass vial, you're drawing up the amount. It's a little bit more clunky to give. So looking at dosing and when to administer, so there's a number of sort of standard pediatric doses here. I'm not going to read over all of those. Looking at timing, and this was from our consensus from the North American consensus, in children whose convulsive seizures are often self-limiting, the recommendation was to give the rescue at 3 to 5 minutes. If the convulsive seizures usually are more prolonged, however, we want to give rescue immediately, and that's certainly what we do for a lot of our younger kids. Every time they have a seizure, or nearly every time they have a seizure, it's a prolonged seizure, we just give that rescue medication right away. If there's clusters of convulsive seizures, then you want to give rescue. there's, I think, less consensus for clusters of non-convulsive seizures. So what happens if the rescue medication doesn't work? And it doesn't all the time work. So what's the optimal in-hospital management of ongoing seizures in Dravet syndrome? And here is that you've already heard the literature is really pretty limited. There was one study out of Japan where they sent a questionnaire out to epilepsy specialists, and they had specialists return information on 99 children with Dravet syndrome. And what was found was that the benzodiazepines, so diazepam and midazolam, worked pretty well, as you can see the lines here in blue. Phenytoin, which we've already heard there's less evidence for, and a little bit of maybe disagreement as to whether it should or should not be used for emergent treatment, did not work as well. And then this is an agent, thiopental, that we use to induce coma, and so it almost always works, but it causes a lot of other issues as well. Looking at the international consensus panel that we just published, there was pretty strong consensus. First line, intravenous benzodiazepines, and so children generally, or persons generally, would have gotten a rescue dose of benzodiazepine at home. When they come into hospital, they should be given another full dose of benzodiazepine IV. The next agents that people agreed on were either IV valproate or IV levetiracetam. The issue with IV valproate is many patients are already on valproate and their blood levels are at the upper end of the range, and so in those situations, you cannot give them another load, right? So that's not going to be an option for those patients. But there's really no consensus on what is the next best option. And I think this is an area where we really are not yet as smart as we need to be. One of the questions that often comes up is, should fosphenytoin or phenytoin, and this is another name for Dilantin, so should this ever be used for status epilepticus in children with Dravet syndrome? When we did the North American consensus back in 2017, there was not a lot of consensus from physicians. 7 said, yes, you could use it, and 4 said, nope, you shouldn't use it, and the family said, nope, you shouldn't use it, right? So there's still not a lot of agreement. When we did our more recent international consensus, there actually was agreement amongst physicians that these medications were not inappropriate to use acutely, and just acutely, one time, not having somebody on these daily, but it could be used acutely for prolonged convulsive seizures. So I think the bottom line is phenytoin should not be considered something that we absolutely must not use for status epilepticus and Dravet. Looking at ER hospital management, I think it's really important to individualize to each patient. And these plans should be formulated by the neurologist who's most familiar with the patient in conjunction with the family, what has worked in the past. Each patient should have a written plan to share with medical professionals. So you don't just want to have your seizure action plan, what to give outside of hospital, but for many of our families, they don't live next door to the big children's hospitals. So if their child goes into status, they don't come to my hospital. They're often going to a much smaller hospital where they may not have that expertise. And so really important for those physicians working in the emergency department to have that written plan so they know what to do when that child comes in. And we generally ask families to keep a copy of that plan on their person in case they have to take their child to the hospital, but also try and house a copy of that plan in the local emergency department. Well, how about non-convulsive status epilepticus? So this is where the patient just has altered awareness, but no rhythmic shaking. The diagnosis here is often delayed, and sometimes it can even, this has been ongoing for hours to days before it's recognized. There's not a lot of clear consensus on what treatment is best. Most people would try a dose of benzodiazepines and then following that with Keppra or valproate. So the bottom line here, I think for treating prolonged seizures, an ounce of prevention is worth a pound of cure. So we really want to get those home rescue medications used. We want to have treatment started as quickly as possible. Status epilepticus and Dravet syndrome can rarely have severe outcomes, and we've heard about the acute encephalopathy, and we really want to avoid that in our kids. In hospital, early benzodiazepines. If that fails, probably levetiracetam or valproate are the next best options. And if that fails, we often use midazolam infusions, However, I think you really want to individualize to what works for each patient. If somebody has previously been tried on, levetiracetam and it never ever works for them, then don't keep doing something that doesn't work. Figure out what works and move on to something else. So you want to individualize to what works for each patient. And some children have pretty unique plans that work for them. I had one child that nothing really worked, and they got a single dose of propofol when they came into the emergency department, and that always stopped it. So sometimes it's very, very unique, and you really need to make that plan together with the family. So happy to take any questions. Thanks.
Great. Thank you. Thank you very much, Elaine. Questions? No questions.
All right.
A quick one.
CBD is part of the rescue. Have you been using that at all?
Yeah, I think that is used. I know in the community there have not been great studies on that, so I guess I would have some caution about using therapy that is unproven, particularly if you're for convulsive seizures where we really want to get those stopped.
Ketamine being used, and I wondered what you thought about that.
Yeah, so I think, again, that comes to the sort of unique plan, the individualized plan. I think ketamine is actually a very good option for children with seizures that have not stopped, beyond the rescue therapy and then a single dose of, what we call refractory, a single dose of another anti-seizure medication. So definitely worth discussing with your provider, yeah.
On the niazolam or the nasal midazolam, what is the reasoning behind it, the age limit, and is there a possibility, is there any discussion of that being lowered?
Right, so the studies were done in the older patients, and that's probably the reason. Having said that, I think, the medication in that is midazolam. That's a medication that we use in infants. So I think it's really the dose, and I must say as child neurologists, we would be out of business if we only did what the FDA told us we would do. We use a lot of these medications off-label. Maybe I shouldn't say that, but we do.
Thank you for a wonderful talk. I have a quick question about the VIMPAT. You mentioned phosphine and the possibly using it as a rescue medication. Does this rule apply to IV VIMPAT for the rescue?
So you can use it as an IV rescue medication, yes? And so I didn't get the rest of your question?
I was asking about VIMPAT as an option from the seizure medications, if VIMPAT can be used.
If sorry? Lacosamide. Oh, okay. Lacosamide, I don't think we have great data on that. And again, I think it would not be one of the first things that I would do, but if you've tried it and it works for your individual patient, I think that's reasonable, but I don't think we lack the data on that.
Wonderful, thank you.
Okay. Well, thank you very much for that talk, Elaine. That was